In the last few years, we've learned a lot about the biological changes of HER2-positive disease during and after therapy, especially during and after neoadjuvant therapy. On one hand, we've learned that by looking at gene expression analysis, there are huge changes at the biological sense, even at 2 weeks of therapy, of neoadjuvant therapy. So on one hand, we and others have shown that a substantial proportion of tumors that are HER2 enriched to start with, so approximately 50% of HER2-positive tumors are HER2 enriched to start with, after 2 weeks of dual blockade, or at surgery, after 4 to 6 months of anti-HER2-based therapy, these HER2-enriched tumors lose their HER2-enriched features and they become Luminal A. So there is a switch from HER2-enriched towards a shift towards Luminal A biology. So we have been very interested in trying to understand what is this biological change. Are we talking at a real subtype changes? Is this clonality? Is this due to real changes in tumor cells? And is this change forever, or is this just a transient change of subtype? So we recently published a Nature Communication paper where we used tumor samples from patients, but also we went to the preclinical setting to try to ask some of these questions. And what we showed at the preclinical level is that we can induce the same changes as in patients. So the HER2-enriched cell lines after anti-HER2 treatment, they become Luminal A most of the times. But this change in Luminal A is not because proliferation goes down or is dropped. It's because there is a whole rewiring of gene expression, in the sense that proliferation goes down, indeed, but many Luminal A-related genes are upregulated, such as estrogen receptor, progesterone receptor, FOXA1, BAC1, for example. So it's a true phenotypic change that occurs in cell lines. Most importantly, what we observe is that this change is transient. So if you stop anti-HER2-based therapy, after 48, 72 hours, the cell line goes back to the original state. And I think this should make us think that potentially this explains why anti-HER2-based therapy and maintenance with anti-HER2-based therapy in patients is useful. Most likely because it makes the tumor remain Luminal A and not go back to the aggressive HER2-enriched subtype. At the same time, we showed at the preclinical level that if you induce this subtype change to a Luminal A subtype, you can respond to different treatment strategies. For example, CDK4 and 6 inhibitors, whereas the HER2-enriched do not. So the same cell line, after changing to the Luminal A phenotype, is more sensitive to CDK4 and 6 inhibition. So I think overall this tells us that we need to study these biological changes, and potentially these biological changes could be actionable in the future if future studies clearly confirm that.